Hey guys, Carl's back to finish up chapter 15 with you, starting off with section 6. We're going to talk about gas exchange and the dependency on partial pressures. And this process of gas exchange we know occurs within the external environment between blood and the alveolar air that goes across the respiratory membrane. The process depends on these partial pressures that are involved and the diffusion of molecules between a gas and a liquid. So the air we breathe is a mixture of gases, and starting with the most abundant and to the least abundant would be nitrogen, oxygen, and then carbon dioxide. We get the percentages of these in the atmosphere due to the atmospheric pressure at sea level, which is about 760 millimeters per mercury. So we use this number to gather percentages in reference to the total pressures. So each gas contributes to the total in proportion, and there's a table that actually shows you the exact percentages of each in your book. It's about on page 519 if you want to check it out. You don't have to know them. But if you added up all the partial pressures, then you would get this total number of 760, which is what we use to determine how much oxygen enters a solution. It doesn't have an effect on diffusion rates of other gases, and you can also do the same calculation with these other gases. But a partial pressure is abbreviated with a P, so kind of recognize that when we start talking about their effects here. Now, as soon as air enters the respiratory tract, its characteristics begin to change. So we see some differences in alveolar air versus our atmospheric air. It's going to become warmer, water vapor is going to increase, incoming air is going to mix with air already retained in the alveoli, so there's a higher concentration of carbon dioxide than oxygen. The last 150 milliliters of inhaled air actually never makes its way past the conducting passageways and will actually again mix with outgoing air. Now, the partial pressures, the way that they affect the pulmonary and systemic circuit are outlined here. We know that deoxygenated blood delivered by the pulmonary arteries has low partial oxygen and a higher partial carbon dioxide. Diffusion will occur between the alveolar air and the pulmonary capillaries. That results in an increase in oxygen pressure and a decrease in carbon dioxide pressure. By this time, it's going to reach the pulmonary venules, equilibrium will be reached. Blood will then enter the pulmonary veins, mixed with capillaries around the conducting passageways, which at this point carry little oxygen. Normal interstitial fluid has a partial pressure of oxygen of 40, while carbon dioxide has 45, and this is going to cause oxygen to diffuse out of the capillaries and CO2 to diffuse in and basically start to balance things out because the exchange is the same. Also, external respiration will replace oxygen released into the tissues, and at the same time excess carbon dioxide will be lost. So this is basically how partial pressures play a role in a balancing act between carbon dioxide release and oxygen intake. 15.7 is going to talk about how we transport oxygen and carbon dioxide. There is a limited amount of solubility in the blood for these two gases, so red blood cells help solve the problem. They take up dissolved oxygen and carbon dioxide from plasma. If it's oxygen, it's going to bind it. If it's carbon dioxide, it's going to use it to make some kind of soluble compound. When gases in plasma are high, excess is removed by the RBCs. If they fall, then RBCs are going to release those reserves to, again, balance things out. 1.5% of oxygen in arterial blood is in solution. The rest is going to be bound to hemoglobin. The amount of oxygen bound or released by hemoglobin is due to the partial pressure of oxygen. The lower it is, the more that's going to be released. If the pH declines and the temperature rises, this will also cause a release of oxygen. A lot of times this can be due to maximal exertions or exercise, because we know that our temperature of our body rises at that point. We'll mention this pH here again in a second. That is involved more with the carbon dioxide transport, which is generated by aerobic metabolism in our peripheral tissues. If it enters the bloodstream, it may dissolve in plasma, and it's about 7% of it does that. 23% of it will bind to hemoglobin within the RBCs, and then the rest of it could be converted to carbonic acid, which will cause a decline in pH. And all of these processes are reversible, but that decline in pH is also going to add to that release of oxygen by hemoglobin. All right, 15A is going to talk about our neurons in the medulla oblongata and pons, and also our respiratory reflexes. And under normal conditions, our cellular rates of absorption should match our delivery and removal at the capillaries. So we should have equal absorption and carbon dioxide excretion at the lungs. If there's an unbalanced results, a homeostatic response is going to occur. This might be a change in blood flow and oxygen delivery. This could be change in depth and rate of respiration. The blood flow and oxygen delivery is local control, while the depth and rate of respiration is under our brain's respiratory center control. Our local control includes the rate of oxygen delivery, like I just said, and the efficiency of pickup by the lungs. So peripheral tissues become more active, our interstitial partial oxygen pressure is going to fall while our carbon dioxide pressure is going to rise. The more oxygen delivered and the more carbon dioxide carried away is what would be the result. If we have an increase in carbon dioxide, this is going to relax our smooth muscles of the arterioles to increase our blood flow. And then the flow of air into the alveoli is going to improve our gas transport as well. This is going to involve airflow directed to the lobules in which the partial pressure of carbon dioxide is high. Centers of the brain are both voluntary and involuntary. So the involuntary component is in the medulla oblongata and the pons. They're going to regulate respiratory muscles and control the respiratory rate and depth of breathing, while our voluntary control occurs in the cerebral cortex. It affects the output of the respiratory centers or of the motor neurons that control the respiratory muscles, which are what our respiratory centers are. And we're going to talk about them in more detail here now. So the respiratory centers are 3 pairs of nuclei. They do include the RRC, or the respiratory rhythmic centers. They're located in the pons and the medulla oblongata, like we just said. Motor neurons that control the respiratory muscles. They adjust the output of the respiratory RRCs, which is what I'm abbreviating this with. Those are actually located in the pons, and they respond to sensory stimuli, emotional states, or speech patterns. Now, specifically, the RRCs, they set the pace for respiration, and they are located specifically in the medulla oblongata, divided into 2 groups, the DRG and the VRG. The DRG is the inspiratory center, or inhalation, and expiratory center is the VRG, which would exhale. Okay, so normal breathing occurs automatically without conscious control. Modification occurs when sensory information is received from one of our 2 reflex controls. We have mechanoreceptors, which respond to changes in lung volume or changes in arterial pressure. This includes the inflation reflex and the deflation reflex, which kind of do what they sound like, keeps the lungs from overexpanding, or is going to stimulate the inspiratory center when lungs are collapsing to obviously reinflate. The chemoreceptors, they watch chemical changes in the blood or CSF. They really closely monitor that carbon dioxide level. 15.9 is going to talk about respiratory performance declining with age. We're just going to talk about many factors interact to reduce the efficiency of the respiratory system in elderly individuals. One is chest movements being restricted by arthritic changes like rib articulations, decreased flexibility at the costal cartilage in between the ribs, muscular weaknesses, and there's also a degree of normal emphysema over the age of 50. Causes a shortness of breath and inability to tolerate physical exertion. This is heightened in smokers, but the problem is there's an inadequate surface area for gas exchange due to destruction of alveoli. Now, I do also want to mention a couple conditions of the respiratory system. Cystic fibrosis is a big one. It's an inherited disease involving a defect of the respiratory mucosa. Basically, it's too dense and cannot be transported, so it clogs up the passageways, and I'll show you a picture in a minute. There's also pleurisy, which is inflammation of the pleura, or the pleural cavities, and what happens is a secretion of excess amounts of pleural fluid makes your lungs heavy, labors your breathing. Here's a picture of a non-smoker versus a smoker's lungs. Obviously, you can see that the lungs are extremely damaged, black, and can cause a lot of problems, especially that increased emphysema. And this is one of the airways within the lungs, showing you that the thick layer of mucus would block an airway, making it difficult to breathe as well with somebody with cystic fibrosis. We're pretty much done. I do think you should check out the system integrator on page 532. Jot down some notes of the connections between the respiratory system and other body systems, and then you will be all set. All right, I'll see you guys next time.